Dr. Varun has already created a base for us to move on to a little higher in diagnostics. So we know, as he has already explained, as little as 0.75 diopters of astigmatism can cause glare and halos and can reduce your quality of vision. The first question that I'm going to straightforward go is toric, for any toric IOL, is topography a must? Well, there are established studies which clearly say that auto K values or manual keratometry values have not been up to the mark in correcting the astigmatism with toric IOL. So we need something more. Now in the market there are optical biometers available and topography available. So we'll discuss of why topography is important in all toric IOLs. It's been more than 2 decades where we know the application of corneal topography in deciding about the incision making as well as toric IOL. I'll just have a small case example here. 60-year-old male having a right eye cataract. We noted an 1.4 diopters of astigmatism on a lens star, and patient counseled and planned for toric IOL. This was the lens we had planned. We had planned in SN683 for the patient. Things looked perfectly fine, surgery absolutely bang on. We had axis of 172 which was coinciding well with the lens. What we had, we were surprised to have a post-operative astigmatism in refraction of 3 diopter cell. So we were like surprised of what perhaps has gone wrong here. We need to actually check it. So this patient had actually undergone with a fellow of for various other types of studies. So he had undergone a pentacam. He had also undergone an eye trace, and I'll be discussing that in detail. This was the pentacam of the patient, and we can clearly see here what we are dealing here is an irregular astigmatism, not a regular astigmatism. If we see just in around 4 millimeter diameter, the astigmatism is 3.2 as compared to what the lens star was showing as 1.4. Just for here the point to make it, the lens star calculates the keratometry value based on 32 point light points that it has. It also has a connector which comes as an additional which is for topography, but we had was the 32 point marker which takes the keratometry accordingly. This is an eye trace. Before proceeding with the slide, I would like to tell that this is here we have to look if an astigmatism is regular, it will be equal in both the meridian, the upper meridian which is the blue and the red. This has been taken at 2 millimeter pupillary diameter, and as we increase the pupillary diameter, we see there is increase of astigmatism, but only in one meridian, not in the other. This is 4 millimeter, increases further. This is 5 millimeter, goes beyond 1, but only in one meridian and not in the other. It clearly tells us what we are dealing here with is an irregular astigmatism, which is potentially not a good candidate for a toric IOL. I am specifying it's potentially not a good candidate. There is a small study of around 200 patients published which says they have retrospectively analyzed topographies of patients who are undergoing cataract surgery, and they have found around 20 to 25% of the patients will have an irregular astigmatism on the cornea with the following reasons like a forme fruste, keratoconus, PMD, with some kind of superior steepening and so on and so forth. So what we are dealing here with a substantial percentage of 25%. But this is just a small study. We actually require a larger database to confirm these findings. So for most cases, your lens star IOL master will do fine, but some subset of the patient might have an irregular astigmatism and they might haunt you for the rest of your life. So what next? Now, once we have come to a conclusion that topography is necessary, the second question is what topography are we looking for? We have so many topography models available in the market today, which are Placido with disc, shine flow, dual shine flow with Placido, so on and so forth. Just for example, the Pentacam, the Opscan 2Z, Topolizer, the Cirrus, the Galilee, there are so many of them. So the answer is primarily you need to get a topography just to make sure that the regular, it's a regular astigmatism and not an irregular one that we are dealing with. And something more which I'm going to discuss further. At some point of time, we have to also be sure that Shine fluid imaging is preferred nowadays because it tells us the anterior surface, the posterior surface also, along with the corneal thickness, and I will be emphasizing about the posterior corneal astigmatism a little later. Now I have the topography values with me. In one hand, I have the accurate keratometry values. What second thing I require is my SIA. For that, we have a simple online calculation available. Just download this Excel sheet, put on your keratometry values, pre-operative and post-operative accurately, your incision size, site, everything, and you get your SIA here at the end of how many cases you do, 50, 100 odd cases, and you'll have a perfect SIA of yours. We know that the factors affecting SIA are many: size, location, pre-existing corneal surgeries like RK, so they can affect your SIA a lot. Something more important recently is corneal biomechanics, which will be discussed in detail later. So now I have my keratometry values ready with me. I have known my surgically induced astigmatism. I know the axial length oblique, the spherical power of the lens that is required. So am I ready to go ahead with a toric IOL? Then the second question is, which toric calculator should I go for? There are multiple toric calculators available online. What should I go for? These are some of the toric calculators that are available online, but are they taking into consideration posterior astigmatism? Is this really important? Well, yes. Earlier we used to say that preoperative disparity between the refraction and the keratometry values might be because of the lenticular astigmatism. But currently we have studies which say that there's fair amount of astigmatism on the posterior surface of cornea itself. For a toric IOL implantation, if I ignore the posterior corneal astigmatism, it would certainly cause an overcorrection in a with the rule astigmatism. It would cause an undercorrection in the patient who is having against the rule astigmatism, and there are a couple of studies who emphasize that. Bayer's nomogram, as we know of, you have to just determine your corneal astigmatism. Little bit too much of mathematical. I will not go into details of that. You determine the corneal astigmatism, you personalize your A constant. Then whatever cylinder that you have, you either have to add your SIA to it or subtract it. Then apply the Bayer's nomogram. This is the Bayer's nomogram, which which takes into consideration your posterior corneal astigmatism also and modifies your astigmatism. Then you define your effective IOL cylinder at corneal plane, and accordingly you have to define the lens that you're going to go for. It's a little cumbersome, but it's pretty accurate, and we have alternatives of this Bayer's nomogram today, and I'm going to discuss that in detail. So Bayer's nomogram takes into consideration the posterior corneal astigmatism, but to be very frank, it's pretty cumbersome. Why not an online calculator? Well, certainly we have today the Barrett's online calculator, which will calculate your lenses for most of the lenses that are available in the market today, as you will see on this side. You just put your K values, you put the axial length. Axial length, we don't put axial length in most of the calculators, and I'll tell you why. Because this calculator per se also calculates the effective lens position, which some of the calculators don't. So this is how it gives us the IOL. It will give you the spherical part, it will give you the toric component, it will also give you the residual toricity that's going to be there. So Barrett's toric calculator, you can go for either of them. So if it gives you a T5, you can go for whichever company you want, you can go for. So it's all in one calculator here. So I'll just give you a small example how Barrett's toric calculator is different from individual calculator. As I told you, the concept of undercorrection and overcorrection. This is the patient who was having a corneal astigmatism, and toric IOL power in this patient showed me to use for a T5 lens in an against the astigmatism rule patient. So when I calculated with Barrett's, it was showing me a T5. So the T4 with a regular and T5 with a normal, T5 with a Barrett's. So it clearly tells me that, okay, this is considering the posterior corneal astigmatism, and it might give me a better outcome. So advantages are certain of Barrett's toric calculator. It's actually all in one, and you can use it for any brand of IOL that you want to go for. These are the various, just a small comparison of various toric IOL calculators available, and you will see that variable effective lens position is present in Barrett's. Barrett's also take care of your IOL power and also of your posterior cornea. So it has certainly various advantages as against to other calculators. Once I have done everything, my topography is done, I have selected the IOL and I put the IOL. What diagnostic can help me post-operatively if I have a post-operative surprise? So accurate alignment obviously is very important, but how do I measure it perfectly? Subjective, it should not be a subjective, it should be objective. So we can do it with an eye trace. If you just go to an internal astigmatism, go to an internal optics, go to an astigmatism, just offset to it, offset to cornea, and you will get, if it's a 0, you add 90. So you will have 90 will be the axis of the IOL, and vice versa. So it's just to add 90 or subtract 90 from it, and you will gonna get the astigmatism. Even in the undilated pupil, this is the much advantage, and it's objective. We had actually done a comparative study which we found that the axis given by an eye test is not at all different from what we can get clinically, but it's giving me more accurate axis as compared to clinical judgment, because on a clinical judgment we have a variability of around 5 degrees, while it can give me a variability up to 1 degrees. There are other things that are available, but these are software based to check the toric IOL axis. What iTrace helps us is iTrace as well as NIDAC OPD3 gives you a perfect bang on axis, and it also tells you how to correct it, will be discussed. So what we are basically looking for today is a pseudophakic visual quality beyond emetropia, and I think that can be achieved with 3 things: a topography, a barometry, and a biometry A scan together, that we call as a TAB for cataract surgery. Thank you very much.